of Mr. Asad Khan. And as we know, the roadmap of our presentation is a brief intro. We will jump to the presentation, and then during the presentation, if anybody has a question, Dr. Asad wants to be very interactive. You can raise the hand and he can answer you during the session, or we can get back to your question at the end. Please feel free to type your name or question and even a brief intro about yourself in the chat box. So we are going to start with Asad, and it's my privilege to introduce him. And we have also Junaid Kalia as a co-panel. Asad is a co-founder and CEO of MEDZnMORE. I will assume it's MEDZnMORE. That's what probably will translate into its meanings and objective. He has raised the 11.5 million. I mean, that's amazing from while having his organization in Pakistan. So that's an amazing startup for any startup company. I always say, actually, Dr. Azhar sent the video yesterday where he mentioned that, my apologies, mentioned that we trust our doctors, we trust our education, and we know we are sick. So that fact is there. But when it goes to the medicine, we have not much trust. So I think supply chain is his focus of today's presentation, and probably a little outside that as well. So with further ado, I will say, Asad, why don't you give a bit of your input, and then we can start your presentation. Thank you.
Dwi, thank you, Dr. Saab. It's a pleasure to be here. First, I would like to congratulate APPNA Merit for building such an amazing platform to highlight Pakistani startups, and hopefully we can not just highlight, but improve some of the healthcare in Pakistan in collaboration. So yes, as Dr. Umar said, Asad Khan, I'm the CEO and co-founder of the largest health tech company in Pakistan. I spent most of my time prior to moving back to Pakistan in 2017 abroad. So I'm going to try and jump straight into the presentation. There is a lot of material. I wanted to keep it as an interactive session. So if anyone online has any questions, just shoot questions while we are doing the presentation. So I've spent most of my time before moving back to Pakistan abroad, 17 years, and primarily in the health tech space. So I wanted to touch briefly upon what my experience were abroad and how Pakistan relate to what's happening in the West, and how can Pakistan benefit from all of the innovation that has happened in the West over the last 10, 15 years. So if you look at the graph, top bottom graph, this is a 10-year funding of health tech across the world. So 2019, for example, if you pick up 2019, health tech received about less than $15 billion. In comparison, fintech actually received about $69 billion. And that's not including all of the hundreds of billions of dollars that financial services and banks have been investing on building the infrastructure, especially the technology infrastructure over the last few decades. Now, the output of that, I normally ask audience in any of the speeches that if I ask people in the room, how many people have their entire finances on touch of a button on their mobile apps? The answer is probably going to be 100%, right? And if I ask the same question about how many of you have got your medical history, entire medical history on touch of a button, I normally see very few hands, right? And so that's not just an incident, right? That's the result of massive investment innovation that went into financial services. So health tech has been, even in the West, health tech is about 15, 20 years behind where financial services is, or for that matter, retail is. So Walmart, Tesco's, they've got state-of-the-art, world-class logistics centers. They have their customer data is crunched using supercomputers. So health tech has a lot of catching up to do. I think recently we saw some spike. For example, in 2021, the amount of investment coming into health tech doubled. And that actually is out of sheer necessity, because healthcare as a percentage of spending in Western economy especially is becoming unsustainable. I'll just pick up one example. So diabetes is probably the usual culprit every time, but diabetes alone in 2020, US spent about $368 billion on type 2 diabetes. That's roughly 2% of their $20 trillion economy. And that number actually doubled in 10 years and is still and is on course to double again at much faster pace. So just one disease in US has the potential to bankrupt the entire economy. So the sheer scale or the criticality of innovation in healthcare, I think is forcing more and more money being spent there. So when I was abroad, most of my time was also spent on doing similar stuff. So I was part of some of the pioneering projects in UK where we were collecting huge amounts of data, primary healthcare, thousands of GP practices, secondary healthcare, local council data. And we were connecting that data at patient level. So we were looking at the entire patient journey across the healthcare spectrum. And then we were looking at where the failings were in primary healthcare, which resulted in patient being admitted to hospitals, etc. And then we took the data at population level, and we looked at past 15, 20 years of patterns, and we were trying to predict. When I moved back to Pakistan, with the company I was leading, we were trying to build some preventative models, see if we can predict onset of diabetes, see if we can predict onset of certain respiratory conditions, looking at the past data, especially from the primary healthcare side. And that's why most of the investment in West that comes into health tech actually goes into deep tech, AI, ML, because they already have built the infrastructure required. They have the health, especially in UK, it's like a treasure trove of data. They just need to build some science on top of it. Now that isn't necessarily a bad thing for countries like Pakistan in emerging markets. So the absence of infrastructure could also be a massive opportunity for impact in these areas. So I normally give one example in this regard. So in Africa, one of the countries, Kenya, their entire financial transaction actually runs on one company. It's called M-Pesa. So they're consumer businesses, small, medium enterprises, etc. They all use M-Pesa. If you compare that to when I moved to UK 20, 25 years ago, there was a company which was trying to do mobile payments, and it couldn't. The reason was that they already had a well-established infrastructure of banking. So there were banks in every high street, there were ATM machines, there were checkbooks, they could use checkbooks, everybody was using plastic money. So the advantage of that mobile payment was just incremental, right? So the adoption was very, very poor. If you compare that to what happened in Kenya in terms of M-Pesa, it was like in a city like New York, there were 20 ATM machines. So the lack of infrastructure of being able to withdraw cash and be able to make transactions actually forced the entire country to adopt a method which was cashless. So in Pakistan, if we just talk about, let's say, health tech, then Pakistan healthcare's infrastructure is very similar, right? So primary healthcare is very patchy at best. Hospitals also are quite fragmented. So lack of infrastructure in Pakistan, could that be the catalyst for adoption of, let's say, telehealth in Pakistan? Because there's no primary healthcare that exists. If we spend on telehealth side, if we bring in innovation in telehealth, could the adoption be faster on digital side? I think absolutely. Same goes for medicines. So in the unavailability of medicines, especially outside of main cities. So even in Karachi, etc., the availability is not that good. But if you go outside of the cities, the availability is really, really patchy. So availability of basic infrastructure, could that force the adoption of online pharmacy in Pakistan? If done well, if done correctly, I think there is absolutely that potential. Now, what in health tech space, Pakistan over the last couple of years, 2-3 years, has really arrived when it comes to the startup ecosystem. In total, Pakistan has probably raised close to $500 million. And most of that came in the last 2 years. But out of that $500 million, health tech has only attracted about less than $30 million. And we are probably half of that. So the catching up within health tech space, like abroad, I think in Pakistan is also great. So it does represent a huge opportunity because not much exists and a lot of railroads can be built in Pakistan. So when I moved back to Pakistan, I initially joined Kareem, and after that, I sat down with my co-founders and we started focusing on what can we do in the health tech space. And there were two focus areas. One area was like many underdeveloped or developing countries, outside of putting food on the table. The biggest challenge families face is when they need to find medical help. So we wanted to build a holistic platform that can simplify access to healthcare services. Access to healthcare services, we can say access to healthcare service includes access to medicine, access to doctors, access to diagnostics, labs, and also health insurance. So that was our first focus. Let's build a holistic healthcare platform with whatever somebody needs. If it can be done virtually online, then it should be on our platform. That was the first part. The second part was when I was abroad, I came across a story on CNN that up to 40% medicines in Pakistan are either counterfeit or substandard. Now, a few months back in September, a Pakistani publication called Counterfeit also published similar numbers that up to 40% medicines in Pakistan are either counterfeit or substandard. Now, that number, if you're sitting in the West, it's incomprehensible. It's insanely high number. So what we are saying is 4 out of 10 medicines, best case scenario is it's just a powder, nothing will happen. And the worst case scenario could be anything. So the second focus area for us was, can we actually remove counterfeit medicines from the supply chain? And if you want to do something with health tech, even if you open an online pharmacy and we're still getting counterfeit medicines that we are sending all over Pakistan, then it defeats the purpose of simplifying healthcare. So that was the second focus area. In order to solve that, we actually looked at the entire medicine supply chain in Pakistan in detail: manufacturers, distributors, their margins, pharmacies, their penetration, how many there are, etc. And it became quite clear to us that solving for counterfeits or removing counterfeits in Pakistan is a much bigger challenge. So I'm going to take a bit deeper, a slightly deeper dive into medicine and supply chain in Pakistan. So the way Pakistan pharma market operates, what the structure is, unlike many other countries, even India, this market is dominated by branded generic medicine. So the brand sells, generic medicines almost are non-existent in the market. If you compare that to just our neighbor, India, in India, up to 70% medicines are generic. So what this results in is, if somebody goes to buy paracetamol, they're going to ask for Panadol or Calpol or some other iteration of that. And for shopkeepers, they actually have to keep multiple brands of the same generic. So the range of products they need to keep in their shops is huge, because they have to keep up to 10, 20 brands of the same generic. Second challenge in the market is it is a very fragmented supply, very fragmented distribution side. So we have few big distributors, but the tail is huge. We've got hundreds of distributors. Even in single cities, you could have few dozen distributors distributing medicines. So what that does is a single shop ends up buying from up to 40 odd distributors, and those distributors only visit these shops on weekly basis, once a week, by and large. So they don't have the working capital that goes beyond 2 days. So they can't buy for the entire week. And the third biggest challenge in this market is up to more than 80% pharmacies in Pakistan operate manually. So they don't have any systems. What it does, they don't have the loss of medicines is percentage is much higher than the normal. Up to 10% medicines are lost to either overstocking or expiry, etc. And you can't build a marketplace model where you can connect all of these different players together to make the market more efficient, because systems don't exist. There is no infrastructure in play, as I was saying earlier, that in Pakistan, not just in the primary healthcare, but just in the medicine supply chain, etc. There is no system. You can't connect all of these moving dots because there's nothing to connect to. So you have to build the infrastructure of a railroad first. Now, what that does is, at a very high level, 90% of the pharmacies in Pakistan face supply shortages due to brand issue and also the broken distribution business. On the pharmacy side, because of the branded, they have limited availability. No pharmacy can keep so many brands. They don't have working capital, so they end up buying for a day or two, and they wait for the distributor to come back. Now, the fragmented supply chain, which is the second one, fragmented supply chain results in, because shopkeepers have to go and buy medicines for the 4 days when the distributors are not coming from a place called wholesale market. That's where the entire counterfeit comes into the supply chain. So up to 40% or 50%, I don't think anybody has the exact number, but that's the research. And then because they're not processes, they don't know exactly how much medicine do they need, the actual forecasting or the expiry, etc. So what needs to happen? I think the reason I wanted to go through this entire mechanics of supply chain, so just to make you understand that, you know, the enormity of the challenge is not just on streamlining the supply chain, but it's the digitization of the entire pharma ecosystem that needs to happen for make this. There are two things that needs to happen. One is working capital limitation needs to be addressed, and that can come in terms of lending and other areas. And the second thing that needs to happen is their frequency of supply needs to improve to these pharmacies, so they can get what they need when they need. Second, because there's so many different distributors, hundreds in certain cases, we need to simplify procurement for these pharmacies. So there's a lot of aggregation that needs to happen within this space. So we currently aggregate around 200 different manufacturers in our warehouses. And the final part is, we need to build an entire operating system for these pharmacies. So the ERP solution that can give them visibility, a digital ecosystem within each of these pharmacies. So that gives them visibility on their inventory side, that gives them visibility on their sales, gives them forecasting, and make the pharmacies much more efficient. So I think when we looked at these two problems, one was, can we simplify access to healthcare services, and can we remove these counterfeit medicines from supply chain? I think the answer was yes. We knew how to do that. I think after initial 3-4 months of research, we knew exactly what to do. But the bigger challenge, especially in Pakistan, but I think right now the entire startup ecosystem is going through the similar learning curve. We wanted to build a sustainable company. So we initially decided to think, can we build a company which actually becomes profitable? Can this company be sustainable? And there were two answers to that, essentially broken down into two different streams. One was, we have to invest on building the right technology stack. So we have to invest. So initially in 2020, we raised about $2.6 million. And out of that $2.6 million, we invested half of that money in building the technology stack, which was very medicine focused. So we built from ground up the entire ERP solution, the logistics solution. So a lot of, and we went into deep details of how the picking needs to be done in warehouses, how the packing needs to be done, so the whole shenanigan. And the other part for us was, we need to work very closely with manufacturers for us to be able to unlock margins. So on one hand, we had to build a scalable system that makes us more efficient than everybody else, and that requires technology. On the other side, we wanted to work very closely with manufacturers. So yes, so we have been lucky since we launched. I think our first warehouse went live in only March 21. And the next slide I'm only showing because when we were entering into this space, there were a lot of there were a lot of question marks that, is it possible to actually digitize the SME side, the retail space, right? Are shopkeepers actually going to use the app? Is the digital adoption going to happen in Pakistan? I used to work at Careem, so I used to head Careem in Pakistan, which was the dominant ride-hailing player. And at Careem, this digitization actually happened with sheer subsidy. So we subsidized the entire ecosystem. Careem was spending about $5 million a month at peak to force users to download apps, etc. And we didn't want to do that. So we wanted to figure out that, can shopkeepers actually adopt apps, start using the system? And our experience has been phenomenal. In last 12 to 15 months, we have been growing at 40% a month. So from this, I wanted to draw was, if we invest in the right use cases in Pakistan, either it's the medicine supply chain side, either it's the telehealth side, or bringing labs and diagnostics to a platform. I think if we invest on the right use cases and there's enough value addition within your solution, I think that technology adoption is there. So Pakistan is starting out. There is especially on the health tech side, I think there's a lot happening on the e-commerce side. Daraz has been around for a while. Food Panda has been around for a while. I think in the health tech side, we're just starting out. The impact on health tech is probably the largest, both in terms of the societal impact and also in terms of the ROI. So I think if what we can, or the companies in Pakistan can benefit from, is expertise and especially the knowledge that sits in bodies like APPNA in US. So we don't need, in a lot of these areas, we don't need to build, we don't need to reinvent the wheel. So for example, the pathways I was talking about, there's a lot of work has already been done abroad. If you can build those pathways for chronic patients on our platform and let the platform manage it, that could be a massive start point. In Pakistan, for example, over 60% of hospital admissions are for chronic patients because there is no disease management in Pakistan. So yes, I think this is the right time for health tech to kickstart. And with that, I'll hand it over back to Junaid and Dr. Hayat.
Thank you very much, Asad. That was really eye-opening. The problems you have hinted. I would probably go to Junaid and ask if he can give the brief comments and have any questions for Asad before we go to the audience. Junaid, please.
Well, I do have a lot of comments, and first of all, fantastic presentation and amazing work you're doing. I'm just going to start with the question, and when everyone's questions are answered, then we can have sort of a comment section. So if you go back to slide 1, the slide before that, which is fine, you don't have to share. And you said that there is a feature in your application that is called generic medication recommender, which you said is one of the prime problems within the industry. Can you please elaborate on that how you're solving this problem within the ERP solution?
Yeah. So there are two parts to that. One is there is no awareness in the market for generics, right?
Correct.
People don't know what metformin is. They know what Ryzek is. They don't know what metformin is. Doctors don't write paracetamol or metformin. Doctors write brands. This is almost 100% doctors write brands in Pakistan. So when a patient takes that prescription to the pharmacy, they insist on getting what's written on the prescription. In terms of substitute, there's about 7 to 8% substitution. The rest they insist on getting the same medication. So one part is that on the awareness side, there isn't much awareness that Panadol is the same. Panadol or similar products are the same as paracetamol, right? You can get paracetamol for 20 rupees instead of spending 200 rupees on buying some branded medication. There is that is the one part that we have. The generics are almost non-existent, in pharmacies. That requires a much bigger solution. for generics to start entering the supply chain and people to start becoming aware that they can buy much cheaper medication. Similar thing has happened in US. Mark Cuban has recently launched a generic medicine company, right? So that can happen in Pakistan, but it's a longer term problem. In the short term, I think it's just the awareness on that this medication, there are similar medications to this. You know, these are 5-6 similar medications and the price points of those medications. So what we try and do on our platform, as soon as somebody searches for a product, we show them all of the similar salts together, all of the similar medicines together, and we show the price points of that of those medications. So if there's a cheaper medication that they're looking for, they can buy something cheaper, which has exactly the same salt inside. So that's the start point for us. Will we get to the generic? I think that is the plan, but it's sometime later in the future.
So one last question.
Because
I'm sorry,
that's
Dr.
more
Rosaire,
of a behavioral change.
Behavioral change, which is truly what, like, for example, if I am writing a script in US, I actually have to click OK to substitute, and the pharmacy can substitute with for any reason whatsoever. How are you solving the counterfeit problem? It seems like more of it is basically monopolizing the whole supply chain in a way that you push out the counterfeit, or is there anything else I'm missing?
Yeah. So let's suppose you walk into a pharmacy with a prescription, and the prescription has six products on it. If the pharmacy has 4 products, likelihood is you're going to walk out and you'll try to fill your entire prescription from a single shop. You know, there was a research done here is that for customers, it's on average, it takes about 2.2 pharmacy visits for them to fill a single prescription. So for pharmacies, the biggest anxiety is how do you stop prescription from bouncing, right? And for that, they have to keep large range of SKUs, large range of products, because they have to keep, you know, up to 10, 20 brands of the same generic. So they have to keep a huge range of products within their pharmacies. Now, the challenge with that is they are dealing with up to 40 different distributors on weekly basis. And those distributors only visit them once a week. Now, none of these pharmacies have working capital that goes beyond 2 days, which means that distributor is going to come after 7 days, but they can only buy for 2 days. So what do they do over the next 4 to 5 days? They actually have to close their shops and go and buy these medicines from a place called wholesale market. These are physical markets that exist all over the country, and they are almost 1/3 of the entire pharma market. So what happens in wholesale? What happens in wholesale market? A pharmacy goes into the wholesale and let's say I need 10 bottles of cough syrup. That wholesale market will give him or give her 5 original and 5 counterfeit, and that's how the entire mixing takes place. So why do they have to go to wholesale market? Because of the shortcomings within the distribution space. If these pharmacies can get what they need when they need at a press of a button, they don't need to go and buy from the wholesale. On top of that, wholesale, they get there's a bit of credit. So if you add lending to that, you can remove this entire leg, which is 1/3 of the Pakistan pharma from the supply chain. If you remove this leg, you've almost solved the entire problem of the counterfeit. So that's what we are doing. So for example, we started from Karachi. So in Karachi, about 6,000 pharmacies have our apps. We asked them, instead of using this notepad, they write on notepad on daily basis what they need to buy from wholesale market the next day. We said, instead of using this notepad, use our app. So 6,000 pharmacies, out of those 6,000 pharmacies, half of those pharmacies order from us on daily basis. They use our app, they make a list all day long, and when they're going home, they press a button and we deliver the next day. So they only need to have working capital for 1 day because they can buy on daily basis. Instead of dealing with 40 odd distributors and shutting their shops and going to wholesale, they have a single point interaction, you know, all in one app. So when I say we are trying to remove counterfeit, we are removing counterfeit is removing this entire leg of wholesale from the medicine supply chain.
Dr. Rosaire has a question. Thank you so much. Fantastic. Yeah, now I understand how the counterfeit thing works. Thank you. Dr. Rosaire, sir.
Thank you very much. Thank you, Asad. This is a wonderful presentation. So I have quite a long history of working with the regulator as an expert. And if you just a few points about the history, back in 1972, the government introduced the concept of generic, if you remember, that miserably failed because of the pressure from the stakeholder, and time to time, they tried and it never worked. So we must understand in the supply chain, a study was conducted by the DFID UK about the supply chain of pharmaceutical and healthcare delivery in Pakistan. You may have seen their recommendations. So the situation is much more complex. So to begin with, just claiming that 40% products are spurious and adulterated drugs, so that is really without any substantiated evidence, and it was challenged many a time, and it was really thrown out because it hurt our export market badly, where we are competing with India and we are like exporting to 52 countries. So that's a separate debate. But coming back, it is the things are so much interlinked. They are like when we are talking about spurious medicine, like the death related to the wrong prescription. So it's a long chain. You spend time with NHS or in UK and US, you understand how the prescription move from prescriber to the pharmacy. So keeping like 80,000 branded generic or 80,000 registered product in Pakistan, no one keep that much inventory, not even a minuscule of that. But the point is this, it is more related to the regulator that they should like have like the system in UK, that in the middle you have the generic name and prefix and postfix is like the company name. So I'm not taking much of your time, but I think it is just to yes, this is going to facilitate when you have the warehousing issues and the products they are available. But as long as there are like 60 to 80,000 generics, no one can keep really inventory of part of them. And another important component, like it's entirely different in US, because you do not have a control on the pricing. The pricing is uniform. So how are you going to differentiate that one product is better than other or vice versa? So, and if there are going to be generic, if the price is same with the branded, how are you creating the difference? So the situation is much more complex and needs to be addressed from all the stakeholders. Then, there is a commercial leverage through the intermediary. They offer the discount and they push the products for this substitution. So the situation is even more complex. So this is just to raise these points that I'm sure you have done so much work, and you must have considered all of these things. Maybe to begin with, as a starting point, this is a wonderful initiative to move in that direction. But over the period of time, when there is a buying in from the manufacturer and from the regulator, and we need to work, as a team to streamline all of these issues. That's the point that we can move in that direction. So it's more of a comment rather than a question. I'm sorry. Thank you very much. Great presentation. So that's all from my side.
No, that was there, Dr. Zaire. That was a fantastic point. And in US, the Mark Cuban's company is basically based on the same problems that we have seen, and the solutions are coming exactly what Asad is saying, that we have to move to one generic company, which actually will have more like a manufacturing label as the origin, the manufacturing, the changes and everything. And we are looking at multiple other companies in US which are utilizing blockchain technology to basically assure a supply chain that is have confidence, and a person can actually scan a label and to look at the whole manufacturing all the way from origin as well. So we are looking at these solutions. And to be honest with you, to your point, US is also still behind in making this a reality. Dr. Siddiqui, sir, you have another question.
Yes, Assalamu alaikum. Great presentation, very informative. I had two questions. One is that, so Mark Cuban from the famous Shark Tank show, a billionaire, and so he has made an effort with a startup to try to solve the problem of high cost of medicines by providing quality generic products, but it's going to be an online delivery. And there's a whole model. You can go on their website and read about it. But I was wondering that if in Pakistan, there's a scope for a similar online type of a drug delivery where the problem of warehouse and quality can be addressed. And when the customer knows that I'm getting a cheaper and a quality medicine, I would prefer to wait for those 3 days for my medicine to arrive. That's question number one. The question number two is there any, so I've been out of Pakistan for about 22 years, but at that time, we would go to a reliable pharmacy to buy any medicine, if it's an antibiotic or if it's just to make sure that we would get a genuine product and not a counterfeit product. So is there a move or a value of doing some type of a quality certification for these pharmacies where they actually have a brand and there's an inspection that yes, they pass a certain level of quality certification that they deliver genuine medicines? Thank you.
Right. Thank you, sir. So let me just start by a couple of comments on Dr. Azad. Thank you for the question, and Dr. Siddiqui. So I think just a quick comment on the counterfeit side. So that number of 40% actually is quite a few research papers. There was a recent research published in September last year. Do they have exact numbers on that? I think of course it's a bit of extrapolation, but the research number, but that's the number I'm quoting from various research papers. And I think, of course, if there are so many counterfeits in the industry, it does impact somewhat, but that source of the counterfeit is neither the manufacturers nor the authorized distributors, right? So anybody getting medicines from those manufacturers directly, anybody getting medicines from the authorized distributors, they can be assured that these are 100% authentic medicines. It's the shortcoming within the distribution space that allows counterfeit to enter the market. So I think that's a differentiation, that it has nothing to do with the manufacturer, etc. On generic side, I think we don't need to look at too far in terms of how the market is operating. India, I don't know if I mentioned that before. India, up to 71% market or medicines sold in India are generics. Right? People go to these shops and ask for paracetamols. In Pakistan, we used to have certain generics, right? We used to have Disprins, we used to have paracetamol, etc. They are almost non-existent right now from the market at this stage. So can we move towards that? I think there was recently, I think a few months back, DRAP actually mandated doctors to write generic, not brands. But of course, I think as Dr. Azad mentioned, a lot more things needs to happen. I think the quality control needs to come in, the inspections and the due diligence and those things needs to happen before actually we can move towards fully towards generic side. And I think we have taken a step backwards over the last 2 decades from generic and towards brands. But yes, I think there is a lot more to that than just manufacturing generics and entering into this market. On Dr. Siddiqui's point, yes, I think it's even if we decide to put up a plant and start manufacturing generics and start shipping it to customers or shipping it to patients, I think there's a whole exercise that needs to happen, or the whole awareness and the behavioral shift that needs to happen before people will start actually buying generics. Right now, because the prescription or the doctors only write brands, so the whole behavior needs to shift, that people should be comfortable in buying generics. Right now, right now it's hard to substitute one brand with another with pharmacies. It's only 8% is the number that a substitution takes place. So before we move into this, I think we'll need to have that behavioral shift, and a lot of awareness needs to happen in Pakistan. The second question was,
That was, yeah, that was more Dr. Siddiqui. Yeah, go ahead,
Yeah.
sir.
The second question was about any pharmacy certification, about making sure that you are getting a genuine product from them.
Yes, I think that, and that's probably a implementation problem on our side. So if I give you an example of Karachi, so we operate across Karachi, Lahore, Islamabad. In Karachi, there are about, I think officially there are about 4,000 pharmacies, but unofficially there are about 6,000 pharmacies. But there are 6 drug inspectors in Karachi, and that's all, right? And that's all the workforce that is on ground to make sure that pharmacies are keeping medicines which are not expired, or pharmacies are not keeping, or the pharmacies are keeping in temperature control environments. There's no counterfeit on the shelves. So if you've got 6 inspectors for a city of 25 million people, the implementation is a challenge. So we thought about, for example, using those QR codes, so we can work with manufacturers and put QR codes on every single medicine. But on the implementation side, customers, they don't know. I think 90% of the customers wouldn't actually know what to do with the QR code, how to implement that. So I think there's a bit of implementation issue on that side. It can happen. For example, some cities are better than others. For example, Islamabad is a much better supply chain. Is much better. The availability of medicine is much better in Islamabad. But any medicine which comes into the market is approved by DRAP. So I think that on its own should be a quality certificate, right? If the approval process of that medicine coming into the market is robust enough, then buying any brand from the shelf, should be okay because it's DRAP approved. So I don't think we need another layer of quality assurance in the middle, but I think the approval process needs to be more robust, and people need to have more confidence in that whatever DRAP approves, it's safe enough to consume.
I just had a small comment. So within the state-specific guidelines here in the United States, the amount of square footage required for the pharmacy, amount of coolers that are required, the backup generators, UPS systems, etc., are mandated. And I know that because if I'm opening a clinic, and Dr. Rafiq may even speak about it, I don't know if he has a pharmacy in his clinic, there is actually a significant amount of regulation that is written and that needs to be followed. And I think you're right. I mean, I think legal structure in itself needs to evolve, and then we have to figure out how to mandate it in the next place. Dr. Hayat has a question, and then we'll go to Dr. Rafiq, and then back to Dr. Uzair for another question. Sir, Dr. Hayat.
Thank you very much. So I think the question is really the approval of the generic based on a certain criteria, which is really the DRAP's responsibility, and they're not doing it. They're not implementing it. They're not doing even the minimum to have sort of assurance where we can say the substitute or the generic is equivalent to the brand product. So educating the public is the one thing, but I think our major challenge is still to educate the regulators, right? So that's one. Then the counterfeit, I mean, which entered from a different route, but also the adulteration or the quality. Even let's say if they go through the process of the approval, they prove they are equivalent, but then how they maintain that level of the quality throughout the manufacturing, that's another. Another aspect is really the cold supply chain. I mean, most of the biologics need the cold supply chain, and Pakistan don't have the infrastructure, and that's a business opportunity as well. I mean, if you look at that point of view. But I said I have a question, because you will see very soon on the horizon, there will be the serialization where you can, at this point, I think it's being implemented in US at the level of unit sale, or they call it like at these third-party logistics. But it's going to be implemented to the unit level. So where you can scan the bottle dispensed to you on your app, and you will know basically whether it's original or not. So I think you, have you thought of that? Like how you're going to implement the serialization with your app, or how to integrate that?
Sure. So even in Pakistan, DRAP mandated that serialization a few years ago. Right now, the last number I know, up to 30% of the drugs available in the market have that QR code that has the date of manufacturing, expiry, batch, and also the serial number and also the serial number on those medicines. But the implementation hasn't happened. So up to 70% medicines still don't have that serialization. I think it's mandated. It was supposed to be implemented, I think, a few years back, but it still hasn't happened. That's, of course, that's a great sign. So if we have a serialization, but on the customer side, vast majority of the customers will not know what to do with those barcodes. If they scan half, so I think 90% of the customers who visit those pharmacies don't even know how to scan a QR code. So customer on their own won't be able to identify or identify which is the counterfeit, which is not. From the enforcement point of view, yes, it can happen, but I think the enforcement machinery in Pakistan is quite inadequate at this stage. So if we have serialization, it will help. Of course, it will help. But just the serialization as it stands right now, would it remove counterfeits from the market? I think it'll take a long time, because a lot of awareness will need to come in for customers, and a lot of machinery will need to be upgraded, which is the enforcement side. So removing that leg from the marketplace, which actually, which is the source of counterfeit, is probably the short way at this stage, but serialization will definitely help.
We will move to Dr. Rafiq for comments, and then Dr. Hussain.
Assalamu alaikum. Nice meeting you, Asad, again after a park lunch in California. I see that it's very complicated, so that's why I'm trying to, digest it and not have many questions. But I do have one infrastructure question. With the interruption of load shedding, and does that affect digitalization or digitization of the whole, not only pharmaceutical, but overall internet and digitization work that you and others Junaid, want to do in Pakistan?
Dr. Ab, good to see you again. Of course it does. I think especially, so even mobile phone battery lasts 2-3 hours, right? So we right now we've got load shedding of 7-8 hours. So does it impact? Of course it impacts. So how customers, for example, shopkeepers or even customers at home place orders, it all requires electricity. The internet becomes unavailable. If you're a purely digital business where everything is driven through apps, then electricity shortages or internet outages, electricity outages, it definitely impacts. But more than that, it also impacts the entire efficacy of medicines. So I don't think any of the pharmacies, I don't think 90% of the pharmacies in Karachi or in Pakistan have any sorts of air conditioning or even a backup generator, etc. So I think prolonged power outages, especially when the temperatures are 40 degrees and 45 degrees, prolonged power outages, I think it does has a major impact, not just on the digital players who are operating purely on the digital side, but also on the efficacy of the medicines which are within those pharmacies. So yes,
have you come up with any solution for that? Like, you're financing medicine, why aren't you financing refrigerators?
I think what I originally mentioned was, when we were building this company, when we were figuring out how to solve these problems, the biggest challenge for us was, can we build it and be a sustainable company, right? Can we build it and be a profitable company, have a unit economics positive at some point? So I think these problems can be solved later on. So we are speaking to quite a few multilaterals right now, and I think there's a huge scope of that multilaterals helping us out, not just building our technology, but in supporting putting infrastructure within these pharmacies. So I think there are discussions, but I don't think a startup can finance or fund these heavy infrastructure projects, but multilaterals definitely can, and we are actually speaking to few of those on those lines. Yes.
I have to tell you a story one day. Dr. Hussain said, and then afterwards, Dr. Hussain.
Assalamu alaikum, everyone. Once again, a very inspiring and educational webinar. My question really is that I think we've had such a tremendous education over the last year and a half or almost that. What is the way forward in terms of the objectives of these webinars for the APPNA group to move forward? I think we have identified the issues and the way forward and the problems. It seems to me that all of us individually are quite busy doing our day job. And I think a nucleus of way forward in terms of impetus and resources need to be put together so that a lot of legwork, lot of thinking work, lot of implementation work can take place so that we can move forward. And so my question is, what is the next step for this group?
So that's not
Dr. Hussain, I'm going to let Dr. Rafiq answer that question, then Dr. Khan.
So certainly that's not a question for Mr. Asad Khan. And we at this point wanted to give him, the stage and stuff. But Sarvat, I think this is going on very fast, and it may lead to merit and this group having a different roles. Because so far we have tried to juggle the two roles, but I think as we're getting clarity, we will have to separate the two roles. And so that work is being done as we speak, and within a month you will see by the end of July.
Thank you, Dr. Rafiq. Dr. Uzair, sir, you had a question.
Yeah, thank you, Junaid, and thank you, Asad. Once again, I have a couple of comments. The last thing first, when we are talking about just the storage part of it, now there are wonderful solutions for storage. They are not electricity driven, and UNICEF is one of the largest buyer for the Africa and the rest of the world. So there are many multilateral agencies. IFC is very generous in funding and providing the support as well as the easy soft term financing. So there are many development agencies that they can promote this idea to maintain the supply chain. But coming back to the first question, when we mentioned about 40% spurious drug, the quality of the medicine, particularly the generic, it's based on two criteria, efficacy and safety. And there is just one yardstick which can determine the efficacy. That is the bioequivalence study. So without bioequivalence study in UK, US, or any developed country, you cannot get registration, which means the drug is as good as the originator. So that is the bioequivalence, right? So for the Pakistan, where there is no bioequivalence, we can't say that any drug is really a quality drug or it is efficacious. So that is a question mark. We can't say it's not, we can't say it is, one thing. The second thing is the safety, because the drug-related deaths are the fourth or the fifth leading cause of death in US, which is a very, very developed market. So that is based on the pharmacovigilance, that we monitor the side effect. There is no pharmacovigilance system in place in Pakistan. So both the parameter, the safety or efficacy, and both of these are the compromised ones. So if we say that 100% drugs are not the efficacious drug, that may be right or wrong. And same stand true for safety. So for the drug, in the medical practice, the first thing is do no harm. That is the ethical practice. So if you are prescribing something which you are not very sure whether it's going to create any difference in terms of efficacy or safety, so that's a big question mark. So unless and until we work at a policy level, really to make it mandatory to have the bioequivalence study, which is must for countries like African countries, like Ethiopia, but to talk of really Pakistan. So whenever we are moving in that direction, there is a big political pressure. Multi-stakeholder, they intervene into the bioequivalence study, but we have to do it. Umar, you have pointed out about this thing. So that's my two comments, which are very important to understand, the spurious medicine concept. Thanks.
We have 4 minutes left. I have one question from the attendee, that why not basically consider interlinking pharmacies as well within your application? Is there a way that, you know, when the supplies are short on one pharmacy, can they basically use your application to borrow sort of not just a central system, but an edge network of pharmacies is built on your application as well? Is that something that you are offering, or are you planning to offer?
Yeah, yeah. I think it's a great question. So there are two models that you can solve supply chain. One is that one model is you build the entire infrastructure of supply chain, and then you distribute to medicines, distribute to pharmacies. And the other model is called the marketplace model, where you don't actually build the rails, but you connect these different stakeholders to make the whole supply chain more efficient. The challenge with Pakistan is that over 80%, I think that's a modest number. I think it could be as high as 90% of the pharmacies don't have any systems in place. They don't even know themselves, right? What kind of inventory they have in place. And that results in a double-digit loss of medicines and expiry, etc. So can we connect these pharmacies together? As of now, it's impossible in where the digitization hasn't happened. But let's say in 2-3 years time, so we are currently building what we call the operating system for pharmacies, which includes ERP system, point of sale machines, digital lending for those pharmacies, payment solutions on top, etc. So we are building this entire ecosystem that whatever the pharmacy needs, we are building that system, and we will be giving out those systems for free and monetize the data that comes out of it in order to pay for those systems. So for us to be able to build that marketplace, what I said at the start, we need to build those railroads first. We need to build that technology infrastructure first, for then market to be more efficient. And one of the areas within that ERP system we are looking at is exactly that if a pharmacy has overstock or some excess stock, they'll be able to put that stock in a marketplace on our platform, and some other pharmacies will buy it. That's one of the use cases we have. But can it happen? Absolutely. Not at this stage. A few years down the line, of course.
Thank you so much. The last question of the hour is by Dr. Saima Taslim, and then I will ask Dr. Hayab to close the session. Dr. Taslim, can you please unmute yourself and ask your question?
I'm very thankful to APPNA. You are in a very wonderful session. My question is this: any system you develop, lot of Pakistani pharmacy student, pharmacy graduate, especially females, working from home as a pharmacy guiders and drug advisors. In working any future, we like to develop certain platform to connect these pharmacy graduate female professionals, those work from home, for the drug advisory and how to use the medicine in better way. Do you have any mind of this type of project in your mind and your future plan?
Sure.
So behavioral change, the most difficult question, right? So let you answer that hard question.
Yeah, thank you, Dr. Taslim. So we have in our call center about 30 odd pharmacists, qualified pharmacists at this stage, because we are an online pharmacy. Any person buying medicines from us, which requires a prescription, legally pharmacist has to view that prescription at least, right? So especially for controlled substances like antipsychotics and Lexotanils and Xanox, etc., they have to look at the validity of the prescription. So we have pharmacists, 30 odd qualified pharmacists in our call center, and they regularly reach out to customers to try and make them aware of, for example, if somebody's ordering for diabetes or asthma, especially for the chronic conditions, chronic patients, and if we don't have a medicine, we have substitutes available, etc. So they do make about 500-600 calls on daily basis on those lines. We don't have a structured program for this awareness side, but it's happening on an ad hoc basis because we have that expertise on hand. If you have that, if you have something in mind, would love to partner, would love to hear.
I do actually. I have a whole team working on neurology specifically, but we'll talk offline about how we're going to be actually doing what we call as a whole patient education or health education. We have been concentrating on clinician education and healthcare clinicians education, but these arms are being more, as Dr. Rafiq said, that we are trying to mature them as we go forward. And we'll keep you posted on those from both the APPNA platform and the other platforms, and we're bringing them together so there is lack of redundancy and increased efficiency in that. Dr. Hayat, sir.
Thank you very much. Wonderful presentation. You touched a very key points and issues which we are facing as an industry, I will say, as a healthcare sector. And those issues really need to be addressed at all levels. So the work is among us. But I think Dr. Samia touched another point which gave me an idea. And also we need to bring these solution or thoughts to the university level. I mean, we need to design the programs who can support these new technology. I mean, somebody was talking to me just yesterday that the FSC and BSc students, they're still doing the salt analysis, like in the tubes and so forth. So I think there's a big gap where we need to upgrade our courses as well. So that's really good. So with that, I think if we don't have any question from anyone else, we should close our session. Thank you very much. Thank you, everybody. Thanks, panelists. Thank you, Azad, and thanks, audiences. And thank you very much for your precious time. Please keep it up. I think it's going to be even more important, this supply chain, especially there is a 12% growth in biologics, and they need a supply chain, and even like counterfeit and expensive drugs are also coming to the market. Okay, perfect. Thank you. Thank you, everybody. Have a wonderful day and wonderful evening. Asad. Thank you. Okay.
Thank you.